Guess I can take this down. Well, here we are, all 10 of us. Maybe we could just all sit in the front and have a brief talk. Anyway, hope everybody's getting their coffee. It's a real honor, of course, to be here. I think we all love this course and certainly love the venue. If I can get this to work. All right, what's the trick? Here we go. Right. So there we go. Again, I should note that my disclosures, I'm a consultant for Stryker. The rest of them are in the AOS website. I don't have any conflicts with this talk at all, and I'm happy to be here. We didn't have as much dancing this time, but that should be part of the schedule next time, I think. Yeah. So anyway, so what we were trying to solve, of course, in the beginning was the rotator cuff deficient shoulder with superior escape and altered mechanics, although now we use it for a lot of various things. Hemiarthroplasty in those days didn't work. People would get superior subluxation and loss of motion and pain. Then they found that total shoulders didn't work for this kind of patient as well because they would get the similar kind of pattern. There were a myriad of attempts to try to come up with a solution for this problem, all sorts of different varieties of implants. Probably only a few of the old timers here like myself remember. I actually took a Kessel out one of the first years of my practice, and I haven't seen one since, so most of these didn't survive. Fortunately, Dr. Grammond came up with some pretty simple features. This is actually from an article that was printed or published in Orthopedics, which means that probably nobody else would publish it. And he had these interesting little drawings of his concept of medializing the center of rotation and then also distalizing the deltoid moment arm by bringing the head down some. So it's really amazing. A lot of innovative things probably happen on napkins. So he first reported his results in 1987. He had this prosthesis, which this is in fact doing this talk. The photo of the X-rays, the first one I've ever found that showed cementing in both components. And he went through his prosthesis went through a variety of different changes and configurations in the 1990s, so it was sort of a continuous change trying to improve the results. They ended up with a Grammond Delta 3. I couldn't find any images of a Delta 2 or a Delta 1, so if anybody has any, feel free to let me know. I'd be interested to see what they look like. But basically, one of the big things was they reduced the head to a half of a sphere so that it wasn't quite so large. That medialized the center of rotation. And then also they changed the glenoid component to peripheral screws so it wasn't cemented. And so this sort of became the prototype for subsequent companies and designs in Europe. It's been noted again, this is just a national utilization trend for in the States. The data shown earlier today reiterates that this is not just in the United States, but is worldwide. So the reverse has become probably the most implanted prosthesis in the world. Now the other side, I'm sort of dividing this into the French story and the American story to sort of try to stay independent of companies. But the first American group was in Austin, Texas, and they in 1992. The company decided that they wanted to get into the total shoulder business, so they formed a team to create both total shoulders and reverses. And this is drawings of their initial implants, and that too also went under some changes. But basically, what they did was they put a central post on the glenoid, and then they used peripheral non-locking screws. They had an all-poly humeral socket and a metaphyseal tray, but didn't really have at that time, didn't have a central screw, which became probably one of their more predominant features. The first ones were done in the United States as custom implants. They weren't really FDA approved, which created a little bit of a problem, but the first patient and second patient were done in 1998, and the first 14 patients with this early design actually had fairly good overall clinical results, which led to increased interest and change in the design as well. So unfortunately, though, the French prosthesis developed some issues with complications. They had a higher head-neck angle, which was one of the things that led to dislocations. The patients wouldn't dislocate out the front, they would dislocate out the side. And they also, with the medialization of central rotation, had issues with notching. And the American type of prosthesis didn't seem to have these kinds of complications. Waiter in 2014 compared those that he had done with the French design to those with the American design. So basically, different head and neck angles and different medializations of the center rotation. The French design had an instability rate of around 2.5%, 2.8%. American design had instability of 4.5%. Notching was a little bit larger with the French design. For some reason, we reported ours as well. Not as many patients, which might have explained some of the differences, but we had a 17% instability rate using the French design and a 72% notching rate, which was almost, I think the highest rate reported was around 80 or 85%. So notching was a major concern. The American design, though, that had a less steep or a more steep head neck angle had almost no instability. So there was quite a difference, and also because it was lateralized, there was a notching rate of only 23%. So as a result, over time, in the past couple decades, the French prosthesis has changed in terms of its design. One way to get rid of the notching is to lateralize the glenoid side. There's actually a talk about that later today. They also brought the glenoid more inferior, as shown in the middle slide. I don't know if I have a mouse here, but you see that? Yeah, so you could bring the sphere down so that there was less chance of impingement inferiorly, and then they also had a lower head neck angle, so they went from being real horizontal to more vertical, which is shown in the far right. The American prosthesis also had to undergo some changes due to their issues because the peripheral screws were not locked into the base plate. There was a significant amount of base plate failure, so that the American group, when they first reported their results, they had a 10% base plate failure rate, which has not been duplicated since. They changed the design so that they had a central screw that was monoblock, and also they had peripheral screws that were locking. They also had a sense that the prosthesis was in too tight, so they went to an inlay humeral tray, and they also created a poly metal or a metal cup for the poly tray, which before it was just purely polyethylene. So they created locking screws. They also found that divergence of the screws wasn't necessary if it was a locking screw because it was rigid enough. And in the study that we had, all of our base plate failures were in the American design that had non-locking screws. So locking screws are actually preferred, I think, in terms of providing rigidity to the systems and creating less failures. So this is actually it's an interesting slide of the American side of the changes that went through in terms of where they are today. So it's interesting that, as you see on the far left, that they had this poly tray, which it almost looks like it's missing. But the evolution of the metal tray over time is also very interesting, and it just shows some of the more subtle changes in terms of what they've done to get rid of or try to solve some of the problems of impingement and instability. So where are we now? I think it's recognition that there are multiple variables that influence the results, not only what you do on the glenoid side, but what you do on the humeral side. Also, the soft tissue envelope is important. The patient that's really stiff like this is probably going to come out a little stiff unless the contracture's addressed. and sometimes they can't really be addressed enough to improve them significantly more. So the current baseplate variables that makes things in the literature difficult to review, but some have a central peg, some have a central screw, some people have both. The amount of offset is important, whether they use interlocking screws or not. There are now wedged base plates, and the follow-up on those is approaching 5 to 10 years now. And then also where the Morse taper is, whether it's in the middle or it's on the periphery, and whether they use screws to keep the sphere on or not. So the sphere variables include whether the sphere is concentric or eccentric, whether it's metal, and now there's a polyethylene version out. Again, some have a central Morse taper or a peripheral Morse taper, and always have to make sure that there's no fluid in the interface. There's also several have a central hole that relies on a central screw fixation, and some have a central hole for extraction, which is very handy in revision cases. On the humeral side, there's long stems, short stems, stemless, curved stems, monoblock. They come with different degrees of head-neck angle. I think most people now are favoring the 135 and 145 range. And then you can always have an eccentric or concentric poly, depending on the system. Just to sort of show you the diversity of implants these days, this is just a summary of the head-neck angle variability in some of the current companies. And as you can see, it's kind of all over the map. So when you go to do a study comparing one variable to another, oftentimes there's many variables that to make direct comparisons difficult. This is a humeral offset. Again, this is only for a demonstration to show how complicated it is when you start to compare different components. You can see that if you look at several variables, it's the amount of diversity in the components is really pretty astonishing. So where are we now? I think that there's recognition that multiple variables can influence the result in terms of design. It's really not clear entirely which ones are the most important. And my personal bias is that I think the soft tissue envelope probably determines to a large extent the result. And I suspect that we may find that might be even more important than the design going forward. One of the other things that's interesting now in terms of the systems and how the biomechanics or the designs are important. There's several navigation systems. They're proprietary. There's also a talk about navigation later today, so I'm not going to go into it too much. I think one of the things that I find a little concerning with the navigation is the suggestion that you can predict range of motion afterwards. None of these models have soft tissue included. And I don't think that there's a huge correlation between the final result and navigation, but there's a talk about that later today. We can duke that out. Again, the results of these systems are all proprietary. None of them have really been published in open literature. The results we do know differ from when you do it by hand, and also we know that the inter-observer and inter-observer reliability is not ideal when dealing with these issues. And also, like I said, there's no soft tissue variables included in these designs. And I think that's going to probably need to be an important variable that we need to figure out. The latest thing that's on the block is custom implants. It's used primarily for large glenoid defects, and it's meant to avoid bone grafting, particularly in these large revisions that have large glenoid deficiencies. There's a talk by this later today by Dr. Dines, so hopefully you have a chance to see what he has to say. But several years ago at this meeting, he and I were talking, and he predicted that someday all the glenoids will be patient customized. So I think it's remotely possible if they could ever get the price down. But just to think that in the future you wouldn't ream, you would just put in a custom-made component. It's kind of an interesting thought. So where are we now? I think patient factors and expectations may be the most important. That was talked about a little bit in the past couple days. Some design features are clearly important in the clinical result, But I think we have to figure out primarily things to get it right so that we don't have as many complications and stress fractures and instabilities and loosening and all the other things that drive us crazy. So it's been alluded to in some of the previous talks in this meeting. What's the most important thing is pain relief, pain relief, pain relief. And that will make for a happy patient. I tell my patients that the goal is to make it so they can reach the top of their head without pain. And that if they get more than that, that's gravy. Some patients want more strength and better range of motion, and there's some things we can do to make that realized. What I do, just to show how conservative I am, I do a CT scan on all patients. I also get a plastic scapular model like this on every patient because it lets me. It's actually, for me, I can get my hands on it, I can look at it, and I think it helps me when I'm sort of trying to shoot in the glenoid to figure out where to put the reaming, the central pin for reaming. I do pre-op planning. I currently use a base plate with a central screw and 4 peripheral locking screws. I use a concentric sphere. I'm not really fond of placing eccentric spheres. I also use a prosthesis that has a 135 head-neck junction. It's an onlay type system, and I also continue to use uncemented long stems because I'm still waiting on some long-term studies with short stems. I also am not afraid to medialize with eccentric reaming. I do that on probably 98% of my cases, regardless of the glenoid morphology. I don't bone graft. If they have a huge defect, then I'm currently using a custom glenoid component. So in summary, I think the designs after Grammond have been really superlative. I think the results of reverse total shoulder arthroplasty is great. The long-term survival is still unknown, meaning the 20 to 25-year survival, the 15-year survival is very consistent with that of total shoulder arthroplasty. It seems though that their design changes every day, and it's kind of hard to keep up with all of them. But I think as a cautionary tale, all the changes should be able to withstand the challenge of long-term follow-up. I want to reveal, though, that many of the slides of this talk were given to me by my best friends, noted here, the French group and the American group, everybody knows who they are. So I want to give a thanks to them, and also a couple of my fellows who helped me get some of the images together and all that. But it's a real honor to be here, and I look forward to discussion the rest of the day about all these different variables. Thank you.